Welcome to the fourth talk in the Parkinson's Foundation 9th Expert Briefing Series. Today's topic is Parkinson's disease psychosis, hallucinations, delusions, and paranoia. I'm your host today. I'm Dr. James Beck, the Chief Scientific Officer at the Parkinson's Foundation, and I want to welcome everyone to today's call. I'm very excited that we've got a number of people who have registered, over 2,700 people. I also want to give a shout out to a number of viewing parties that we have going across the country. Our Heartland chapter in Kansas has one, our Ohio chapter, our Minnesota chapter. I also want to give a shout out to a group of occupational therapists from Christ Medical Center in Oak Lawn, Illinois. We have over 1,500 people with Parkinson's disease and their care partners, over 300 allied health professionals, over 150 nurse and nurse practitioners, nearly 50 physicians, and an equal number of scientists today. I also want to mention that these webinars are not created in isolation. This is something the people who are longtime listeners have heard me say, but I want to emphasize that this is a collaborative effort with our community. And I'm really pleased to say that our partner Parkinson's organizations who are members of the Alliance of Independent Regional Parkinson's Organizations, or AIRPO, have contributed greatly to this program. I would also like to acknowledge that our sponsors for this series, AbbVie and Lundbeck. These are our pharmaceutical partners, and without their generous support, these webinars would not be possible. So thank you very much. For those of you who are looking online right now at the slides and on the screen, and you want to download a copy, you can. So if you look in the lower left-hand corner, there's a link for download slides, and you can download a PDF of the slides that are going to be presented today. If you happen to be a health professional, we've got good news for you. There's an opportunity to earn one free Continuing Education Unit, or CEU, and this is through the American Society on Aging. So if you registered as a health professional and indicated you'd like a CEU, you'll receive an email by the end of today with instructions on how you collect your CEU. You have just 30 days, though, so keep that in mind. That's until March 27th to collect that free CEU. So now it's my pleasure to introduce our speaker for today, and that's Dr. Christopher Getz. Dr. Getz is a professor of neurological sciences and pharmacology at Rush University in Chicago. It's a Parkinson's Foundation Center of Excellence and Research Center, and he serves as the director of movement disorders program there. Dr. Getz leads one of the world's largest group of Parkinson's experts. And I have to say that he is a renowned expert in his own right. He's one of the nation's leading experts on movement disorders and has published over 350 peer-reviewed articles and over 200 book chapters in the field. He's got broad interest in movement disorders and Parkinson's disease in particular, and has contributed greatly to the science in this field. So it shouldn't surprise you that Dr. Getz is currently the president of the International Parkinson's and Movement Disorder Society. This is the leading group of experts in the Parkinson's field. And so he is recognized as a leader and elected president of it. He's been a member of many neurological societies and organizations. He's editor of many particular journals. And because of his great scientific contributions and willingness to collaborate, especially overseas, he's been elected to the French Academy of Medicine, a National Academy of Medicine. He's a former Fulbright scholar, has worked for 2 years at the College of France in Paris. So it's with my great pleasure to introduce Dr. Getz. Dr. Getz, to welcome Dr. Getz.
Thank you, Jim. It's a privilege to participate in this Parkinson Foundation Educational Forum. So I have been elected to talk about psychosis, and so I'm going to move through some slides and then hopefully leave a good amount of time to address the questions of this very large and varied audience. So let me start with my presentation. I think you have the slides there, and let me go to the next slide to get going. There are 4 learning objectives. I'm hoping that at the end of the session today, everybody will understand what behaviors and experiences fall into this category of what we call Parkinson's disease psychosis. Some people call that PDP, but it's Parkinson's disease-related psychosis. Typically, this is a chronic and a progressive condition. I want everybody to remember those 2 adjectives, chronic and progressive. Second learning objective is to recognize that medical illnesses that cause sudden confusion can also cause hallucinations and psychosis. And when there is a sudden change in behavior, one must go to one's regular physician as the first doctor to consult, because so often this is due to an infection, and that is not the chronic and progressive Parkinson's disease psychosis. Objective 3, to list strategies that patients and caregivers can utilize to reduce or to minimize psychosis in Parkinson's disease, so that there are many options that patients and caregivers can do themselves. And finally, to review treatment interventions, and those usually involve the physician. So number 3 is mostly patient and caregiver. Number 4 is physician and patient. And we have 2 things in the first 2 objectives. What is the Parkinson's disease psychosis, and what is not the Parkinson's disease psychosis? We'll go through all these during the talk here. All right, we have to have a couple of definitions. Psychosis itself means altered thinking with disruption of a patient's ability to distinguish real from unreal. So this is a breakdown in reality, a breakdown in the difference between what one is thinking about and what one is experiencing in the real world versus a misperception. Hallucinations are part of psychosis. They are a false perception, and they will fall into various sensory domains. You can have visual or see hallucinations. You can hear hallucinations. You can feel on your skin a hallucination, or you can perceive something that's not there behind your back, a sense that somebody is there, but actually isn't. It is a false perception. A delusion is a more complex abnormality, and that's really altered thinking, where there's a fixed conviction that something is real when it actually is not. So the example I give on the slide is my house has turned into a car dealership. This is a true story. There's a real patient of mine whom I saw recently. He used to sell cars. Now his house has become the car dealership, and he's convinced of it, and there's nothing that his family and he can do to get him around that. That is a delusion. And paranoia is a part of a delusion in which there is the dominant feeling is one of suspiciousness, fear, or concern about safety. All right, that's a safety concern. These are words that we'll use throughout the talk today. The important thing about the Parkinson's disease psychosis as an entity, the topic that I'm addressing today, is that this is a problem where there are hallucinations or delusions, and they occur on a chronic basis, largely in the context of Parkinson's disease being treated by dopaminergic drugs. Not Parkinson's disease untreated, but actually Parkinson's disease treated. And we could talk about the issues of, could this possibly occur when there hasn't been any drug exposure? It would be extremely rare. Let's think of this as a chronic condition in the context of Parkinson's disease and treatment. And that is different than sudden confusion, agitation, and hallucinations that can occur when a patient gets a pneumonia, a urinary tract infection, or is recuperating after surgery in the context of pain medications. That's a different syndrome. It's often confused, but I want to make that distinction very, very strongly with you today. An acute decline in the context of being ill is not this chronic Parkinson's disease psychosis. All right, now when doctors rate the hallucinations or the psychosis, we generally refer in Parkinson's disease to a standard scale. And this now is called the Movement Disorder, or MDS, revision of the Unified Parkinson's Disease Rating Scale, right? It's a scale. And one item captures global issues of hallucinations and psychosis. And this is the question that your doctor is likely to ask. Over the past week, have you seen, heard, smelled, felt things that were not really there? And if the answer is no, it's 0. and you look on the bottom of the responses, normal, no hallucinations, no psychotic behavior. But if the interviewer finds that you are wavering or that you endorse that, yes, you have had something like this, he or she will try to gain more information and to rate the severity. And so let's just walk through the severity. The slight would be there are illusions or misperceptions or non-formed hallucinations, but the patient still recognizes that they are hallucinations. There is no loss of insight. That is considered a slight hallucination. More severe, but still ranked as mild, is called a formed hallucination, where you see a child, a dog, a kitty cat. You see something that is absolutely looks real, but you know it is not real. There is retained insight that it is indeed a hallucination. That would be rated as a 2. More severe is formed hallucinations, a child, a person, a brother, somebody, but with loss of insight. You actually think the person is real, and you need to be convinced by your family or your doctor. And severe means there are actually the delusions. The house is a car dealership. There are people in the house, and you cannot get rid of them. There are people trying to harm you or your loved ones. Those would be the ranking from normal, absent, to slight, mild, moderate, severe. So when you're thinking about how the doctor thinks about these hallucinations, you see the gamut and how severe these actually can be and what a infringement on your quality of life it actually can be. This is not a small problem. Now, at the beginning of my career, not very many doctors were interested in this, and my close colleague, Carly Tanner, and her picture is here. She works in California, still a very, very close colleague. And I'll show you a variety of different doctors interested in this area of research because there is a large audience here, and you're geographically spread. And some of you may actually have these pictures as your own doctor. So I share with you. Dr. Tanner works in California at the University of California in San Francisco. She and I did a project early in our career to try and understand. And this picture is a picture that one patient, not of ours, but of our colleague in New York, drew of his hallucinations. We found that out of the hallucinations, 90% are visual. So there can be auditory, there can be tactile, but most are visual. Most are people or animals. Most have vivid coloration. Some, not most, but some can be frightening. Most of them occur at nighttime when the lights are dim. And what's particularly interesting is that they are repetitive. They're not random. The same picture comes back to the patient. A man with a raincoat, a little girl with a lace dress, a little puppy dog with a red collar. These are repetitive, and they become familiar to the patient. And this is the typical pattern of this chronic hallucinatory syndrome. We found that 70% developed it for the first time in the context of a change in their medications. In the past, we used a lot of what are called anticholinergic drugs. This was in the 1980s. These drugs are not used very much. Dopaminergic drugs are used. Usually, these hallucinations start for the first time in the context of increasing the medications. And all of them at least improved when the medications were reduced. So while they are not specifically just from the medicine, they are exacerbated by the medicine, and one can manipulate these hallucinations by being attentive to the drugs that the patient's taking. The risk factors for developing hallucinations have been studied by two of my colleagues, Sanchez Ramos and Gilles Fenelon. This is an international audience, so I give you some international colleagues as well as American. They looked at various numbers of patients with hallucinations and without hallucinations. In the Sanchez Ramos group, 26% of the patients had hallucinations. In the French study, 40% had hallucinations. But the things that were associated with hallucinations were, in both studies, cognitive problems or memory issues, the presence of depressive symptoms, sleep problems at the same time as the hallucinations were occurring. But then things started to break down in terms of a similar pattern. One study showed that the patients who had long duration of Parkinson's disease tended to be those who developed hallucinations. But that wasn't consistent in both studies. Also, age, being older, gave a higher risk for hallucinations in one study, but it didn't in the French study. What's very important, I think, is that if you look at the dose of medicine at any one time, the absolute dose is not associated with the hallucinations. A change in the dose of increasing whatever it was before, that does increase the hallucination risk. But just looking at the dose, and many patients ask me, doctor, am I on a high dose or a low dose? That's really tricky to do for hallucinations. The question is, are we able to keep whatever dose you have stable, or are we pushing it upward? Because when we push upward, we increase the risk of unleashing hallucinations. In terms of delusions, I show you my colleague Jennifer Goldman, who is very interested in cognition and also the allied diagnosis of dementia with Lewy bodies. She found that delusions occur in about up to 30% of patients who are hallucinating. So once those patients are hallucinating, if they are delusional, they're scored as a 4, an advanced patient on that hallucination scale. They are more frequent. The delusions are more frequent in demented patients than the non-demented patients. And they're rare to occur without hallucinations in Parkinson's disease. They can, in this alternate diagnosis of dementia with Lewy bodies, to have pure delusions without hallucinations. But within Parkinson's disease, that kind of graded scoring system that I showed you with the score, the rating scale, is quite consistent for Parkinson's disease, from minor hallucinations with retained insight, formed hallucinations with retained insight, formed hallucinations without insight, and then on top of all that, delusional thinking. That's the pattern for this psychosis in Parkinson's disease. There can be different kinds of delusions. There are negative delusions, which are usually paranoid, persecution, and infidelity delusions, but there can be pleasant, complex, and elaborate. People can think that they're living in a garden, or they're at a hotel and it's very nice because there's so much service at the hotel, and they're happy even though their family is quite distressed for this delusional thinking. The negative is more common actually in Parkinson's disease. Now, I think that people are concerned about what happens if I develop one of these hallucinations. Is this a one-time deal or is it not a one-time deal? And this was a project that I embarked upon with several colleagues, and it took over a decade of work. So it involved many people and some very complex statistical work. The picture that you see is Dr. Sue Lurgans, who works with me, and she is a very sophisticated statistician, and she helped to design this longitudinal study where we took 89 Parkinson's disease patients and enrolled them in a commitment to be involved in an interview study for a decade. And 29 of them already had hallucinations, but the bulk of the patients did not have any hallucinations. And that's the important thing, because I was interested in what happens if they develop. Would we get them for the first time, and would it be an intermittent or would it be a progressive condition? And what we saw here, if you look at my bar graph, those yellow bars, at baseline, as I said, 29, about 30% of the group had hallucinations. But if we simply follow these people with sequential interviews, you see that this is getting more and more common as time goes by, to the point that at 10 years, over 60% of the cohort had active hallucinations. That once one develops hallucinations, you are on the conveyor belt to continue to have them, and that they're going to get worse. So let me just walk through where I have these blue arrows. The odds, or the likelihood of hallucinating, increases annually in treated Parkinson's disease. The odds of continuing to hallucinate, if you have hallucinated in the prior interview, also increases on an annual basis. And the odds of having those hallucinations get worse in terms of the severity that I shared with you on that rating scale increases annually. And so at the end of 10 years, only 4 of the original patients were still non-hallucinators. Many had died because this is a 10-year study. But the fact is, most patients who start to hallucinate will continue to hallucinate, and the number of never hallucinators is very small after 10 years. That's a sobering statement and relates to us in our responsibility to try and identify hallucinations and to see whether we can reduce them, maybe not eliminate them, but reduce them as soon as we identify them. Now, the outcome of hallucinations, what I was concerned about was what happens to the family, what happens to the patient if hallucinations start. And I was faced with the issue early in my career that some patients in my practice were going into nursing homes. And it was not clear to me why patients were going into nursing homes. What was the straw that broke the patients or the family's back and forced them to a decision to go into a nursing home as opposed to staying in the community? And I felt that there were 3 different likely possibilities. One is that the Parkinson's disease motor severity, their walking, their stiffness, their tremor, simply got to be too much. The second possibility was that cognitively they were declining and their families couldn't handle them or they couldn't handle themselves at home. But third, because of my research in hallucinations, I wanted to look at just the fact of the hallucinations. Was that what was pushing them to that decision? So I worked with my colleague, a neuropsychologist, Glenn Stebbins, whose picture is here, to try and ferret that out. And we looked at all patients who went into a nursing home over a 3-year period, and we matched them for age, gender, and Parkinson's disease duration with a patient who stayed in the community. And what we found was that, in fact, the motor severity of the Parkinson's disease did not separate a nursing home decision versus keeping. Families were very able to accommodate even severe Parkinson's disease. They were able to accommodate that at home. That did not separate a nursing home choice. In fact, dementia didn't either. Some patients had dementia, some patients did not have dementia, but that did not separate those patients and those families who ended up in a nursing home. But the fact was that in the hallucinators, 82% of those who ended up in a nursing home were hallucinators, and only 5% of the patients who stayed at home were actually hallucinating. And families, when we went back and debriefed, the hallucinations absolutely broke their stamina because these hallucinations kept their family member up at night, kept them agitated, prevented sleep, and it simply was more than they could handle. And the mortality over 2 years, when we went back and followed these patients, all the patients who were in the nursing home had died. 33% of the patients who stayed at home had died. 67% were actually still at home being managed by their family. So the presence of hallucinations and the chronicity of the hallucinations does have an impact in terms of morbidity and outcomes. I was interested in actually what's going on in the brain, because here is an entity where I cannot see what my patients are seeing, and I wanted to understand the actual anatomy. And so we took a group of patients who were hallucinators, actively hallucinating, and a group of patients matched again for age and duration of disease who had not hallucinated ever. And we put them into a scanner and gave them a visual stimulation. And these are pictures that show what happens when you give a visual stimulation. On the top panel is a stroboscopic, or just a flashing light, a very primitive visual stimulation. The bottom is a moving target, a little red ball that bounces around and forces the patient to pay attention. And the differences between the top of the top panel are the non-hallucinators, and then the hallucinators to the same stimulus. So let's just follow the top panel. The typical pattern when I flash a light in a patient who is Parkinson's disease but a non-hallucinator, all that visual information consolidates in where that yellow ball is in the back. That's the visual brain. That's where visual stimulation should consolidate. And patients with Parkinson's disease handle that information in a completely normal pattern, no different than in their caregivers or a patient who has a different disease. That is a typical visual cortex registration of flashing light. But look at the hallucinators. Again, the second row on the slide, still in the stroboscopic, and look what's doing with the hallucinators. The back part of the brain does not consolidate that information. In fact, the patients who are hallucinating poorly register in the back part of their brain, and instead all that visual information is projected up to the frontal lobe of their brain, which is where we think, where we imagine, those are the areas of the brain that are activated during dreaming, as if this were a false activation. Very, very different than the non-hallucinators. If we look at the kinematic or the bouncing ball, the non-hallucinators, this would be the third row, those patients consolidate their information in what we call the MTV5. That's just a term, and you can see on that right side of the brain in the back, that's a visual moving target area. That's normal, but that's not at all what the visual hallucinators are having. The bottom row, they're getting all kinds of activation, again, up in their frontal lobe. These are very, very aberrant and very distinctive when patients are chronic hallucinators. Now, so the trait of being a hallucinator, we can see that on the patient's brain. Non-hallucinators, when you give them visual stimulation, the information stays in the occipital lobe, it stays in the temporal lobe, it stays in the posterior parietal lobe. All of that is in the posterior visual brain. But that is not the case. It's not the case with the hallucinators. They are processing everything anteriorly in the front part of the brain and not able to keep it in the back part of the brain. So we can look at a brain registration and we can see the difference between a group of hallucinators and a group of non-hallucinators, which gives us an anatomy for the first time to try and treat hallucinations or treat them, especially at the very beginning of their generation. What those studies were studies of people who were hallucinators. But people rarely will actually hallucinate in the scanner. That's just an observation. And I had the rare opportunity to meet one of my patients who was a distinctive patient because he was hallucinating almost full time. Let me just show you this patient. This was a 66-year-old man, had Parkinson's disease for 4 years, and he was on levodopa. Then his outside doctor added ropinirole, and when he received the ropinirole, he developed almost continual visual hallucinations. These were highly circumscribed. They were African tribesmen. They were chimpanzees on his roof. They were Civil War soldiers. He was completely alert, cognitively normal. He recognized them as hallucinations, but they were so frequent, they bothered him all day, that he would have up to 50 episodes. So I had never actually had a scan of a patient having a hallucination. I had scanned people who were hallucinators and non-hallucinators, but not people who actually were hallucinating in the scanner. Well, this was my opportunity. He was very willing to come into the scanner, and what we saw was, in fact, very similar to what we were seeing with the chronic hallucinators. The frontal part of the brain was overactivated. That's the yellow part. And the blue part of the brain, the posterior brain, was underactivated. This work was done with my colleague, Christina Vaughn. Her picture is here. She works in Colorado, and some of you may indeed be her patient, and you are lucky if you are, because she's a gracious and very intelligent doctor. But this shows us that what happens when you are a chronic hallucinator and it's showing on the scan is also what's happening during the actual hallucination. So as we approach treatment, what do? The first issue is to make sure we know what we're dealing with. So we first want to make sure we are not dealing with that other condition, the acute, very ill patient who out of nowhere starts to hallucinate, but it is in the context of a supervening illness, either a urinary tract infection, a pneumonia, or maybe another doctor has started some medicine that is getting into the brain. There are bladder medicines that can get into the brain. There are a number of medicines, especially pain medicines and narcotics. If somebody suddenly starts on this pathway, you want to go to your family doctor first. This is something that's emphasized by the man whose picture is shown. This is Dr. Joe Friedman from Rhode Island. And again, some of you may be his patients. But always be considering, did you start a new medicine? Is there an error in the current medicines? Did you get the wrong thing from the pharmacist when you went for your renewal? Check these things carefully, because if it's a sudden change, that is an acute delirium and really is not the same as this Parkinson disease psychosis, chronic and progressive, as opposed to sudden and very exotic, and really in the context of great, great confusion and agitation. What can we do at home? And this is important. I know there are lots of caregivers on the conference here, and there are things. One thing that we've noticed, and you remember my slide of the Fenelon and the Sanchez-Ramos slide, both studies found that poor sleep habits were largely associated with current hallucinations. And it is very important to encourage good sleep habits. Getting to bed at a reasonable hour, not watching the night news with reports of terrorisms and killings and agitating things, that you turn the computer off, you turn the television off, you take a nice hot bath, you relax, try to get good sleep habits. That is called sleep hygiene. I recommend that we keep lights on with little dim lights so that we decrease misinterpretation of shadows. So often a person will see a man where it's actually a lamp in the corner, but you misinterpret because of the dim lighting. To put enough light on so that the patient can see what's in the environment. There's no doubt that there is a risk of going to hotels, going for overnight visits to unfamiliar homes, unfamiliar places. Those put a patient with Parkinson's disease at a disadvantage because hallucinations can crop up. So to be aware of that, not to stop traveling, but simply be aware of it. There are coping strategies, and I put a picture of Dr. Nico Diederich. This is an international audience, and Nico is from Luxembourg, and he has done studies of patients and their families and found that patients often recognize that the hallucinations are false, but he encourages that we all make sure that the patient understands you're not going crazy. This is seen in Parkinson's disease. Eliminate these hallucinations. Think about something else, but don't worry that you're developing schizophrenia. This is part of Parkinson's disease. We don't want to overreact. We can dismiss them, but you can't play into them. I mean, I think that this is one of the things that I've seen many caregivers say, I don't want to deal with it, so I just say, okay. But I would not encourage that. I would correct, do not engage, do not enter into a conversation with the hallucination, and to say, no, remember what Dr. Getz has said, these are not real, and our job is to dismiss them and try to stare them down, not to engage, and to move on because we're busy and we don't want to have this interfere with our lifestyle, to really try to dismiss them. This can be easier said than done, but we don't want to engage and to reinforce that these are real if they are actually hallucinations. One of the strategies is to really look then if we do have these emerging hallucinations. They are chronic. They are progressing. Your doctor needs to look at the medicines, and you need to look at the medicines. This is something that my colleague Dan Weintraub, who is at the University of Pennsylvania in Philadelphia, emphasizes, is that many of our medicines for Parkinson's disease are complementary add-on medicines, but they're not essential. They're not absolutely essential to one's quality of life. There are many medicines that are used to simply try to improve, but it's not worth causing hallucinations. The whole class of anticholinergic drugs is one that I would have everybody listening reflect on. These are medicines that are by and large old. They are the earliest treatments for Parkinson's disease. They come from the 19th century. Their origin are botanical agents. There are synthetic ones that are used still. They are called trihexyphenidyl, piperidine. Even agents like Benadryl that are over-the-counter can cause hallucinations in the context of Parkinson's disease. And to be very, very careful about why am I on this medicine? Do I need to be on this medicine? And to get off of these medicines if you can, because they can be associated with hallucinations. Amantadine is a very good drug, but it is associated with hallucinations, and it is usually not an essential medication. And the milder medicines, monoamine oxidase inhibitors, such as selegiline, such as rasagiline. There's a new agent, safinamide, which is a monoamine oxidase type B inhibitor. Be careful on these medicines, that these medicines might be an option. If hallucinations are starting, they may not be so essential to your treatment for the core Parkinson's disease that you can afford to get off of those, and hallucinations may improve. The reduction of the primary medicines, this becomes a little bit more tricky. But as Dr. Weintraub emphasizes, the agonists, those are ropinirole, pramipexole, rotigotine. You might have to lower those doses to get rid of hallucinations or to make them more manageable. Or you might have to reduce the levodopa to make the hallucinations more manageable. And that may pay a price. You may walk a little bit less steadily. You may have more tremor. And one has to weigh one problem versus another. You don't want to overtreat the Parkinson's. You don't want to have the hallucinations. Many patients, by reducing their medicines, working carefully with their doctor, they actually can get to a point where their hallucinations are gone or are minimized, so that using the strategies that I spoke about in the earlier slide, they can manage. And they don't have to go on specific medicines for hallucinations, because the more medicine we're taking, the more we put our patients at risk for the expense and also the side effects of medicines. There is, in the movement disorder, Parkinson's disease world, there is a document that I think many of you would like to be familiar with, and this is called the Movement Disorder Society Evidence-Based Review. It's an annual document on the Internet that looks at all the agents that are available to treat Parkinson's disease in its various aspects. And it rates each treatment as efficacious, meaning effective, likely efficacious, insufficient information to make a judgment, unlikely efficacious, or not efficacious. This program is run by Dr. Susan Fox, who works in Toronto. I show you her pictures. Some of you may be Canadian and see her. But this is a document. I put the website access because you want to keep up to date on the various agents. And the two that have been looked at for psychosis have been clozapine, which is an agent that is available. It has been rated efficacious, but it does require specialized monitoring. The usual doses are very low, 6.25 milligrams a day or up to 50, not real high doses as are used in other medical conditions. And frequently you have to have blood counts, all right? You cannot get this medicine without agreeing to frequent blood counts because it can lower the white blood cells. And if it's caught and you stop the medicine, there's no problem. But if it is not caught, it could damage the blood cells and the bone marrow. A second agent that has been utilized clinically is quetiapine. And in the evidence-based review, this was felt to be insufficient evidence to make a judgment. There have been generally positive impressions of this drug, but inconsistent results in the double-blind studies. If this is used, my own experience is that it helps to promote sleep. It really helps to promote sleep, and if patients can sleep better, sometimes they're better able to tolerate or to cope with their hallucinations. But as a hallucination drug, I've not been impressed that it's been helpful. Some of my colleagues disagree with me. The actual clinical trials do not support its use. The usual doses, if it is going to be used, is between 12.5 and 100 milligrams, usually used only at nighttime. There are two other agents that I want to bring a little bit of light to. There is an agent called olanzapine that was reviewed by the evidence-based review, and that is unlikely efficacious and felt to be not useful. It exacerbates the Parkinsonism. This is not something that I would want you to be using without discussing very, very clearly with your doctor because the evidence is against its use. There is a fourth agent here, and this is called pimavanserin. It's a new agent on the market now. It has not been officially reviewed by the Movement Disorder Evidence-Based Review, but it is likely that when the 2018 review is posted on the website, that it will be rated as efficacious and clinically useful. 2013, the American Academy of Neurology had a presentation that showed statistically significant improvements in the psychosis compared to placebo in Parkinson's disease patients. The FDA approved this drug specifically for Parkinson's disease psychosis in 2016. The usual doses are 17 milligrams, 1 capsule, or 34, 2 capsules at nighttime. So this FDA approved, not reviewed specifically by the evidence base at this point, but likely, in my view, that it will receive that labeling once this new 2018 edition of the evidence base is published. Non-neuroleptic, those are agents that block dopamine receptors. There have been some studies of memory medicines. Some of you may recognize these agents, donepezil, rivastigmine, galantamine. These are agents used to help with memory. They're called cholinesterase inhibitors. No double-blind, no rigorous study has been done in Parkinson's disease, but hallucinations are more common in the context of Parkinson's disease dementia, and these agents are used in Parkinson's disease dementia, and better cognition may, in fact, improve one's adaptive reserve to be able to try to dismiss these hallucinations. These agents are taken near bedtime. They do help with memory, and they may help with hallucinations. Dr. David Byrne, who is from Great Britain, he has done much of this work with the cholinesterase inhibitors, so I show his picture here. He's a fine colleague. So the question that I would like to, because we're rolling down to the end here, is should we consider these hallucinations really important? All right, I've spent much of my career feeling they were important and studying them, but I have not rallied for many years of my career a real sense from my colleagues that they were important. Now I think I have their attention. We do know that they are a risk factor most associated with nursing home placement. And that alone is a reason for me to consider that it is important to recognize them and to treat them. And we know from the studies, the 10-year studies, that hallucinations are progressive and they are more and more disabling. They may start as pleasant or emotionally neutral and with insight, but then they progress to being confusing and bothersome without insight, and they can lead then to delusional thinking with paranoia, which is a horrible, horrible state for the patient and equally horrible for the caregiver. They are demoralizing, they fragment the home life, and so I place here my main nursing colleague, Lucy Blasucci, because she takes the phone calls and she is very much convinced these hallucinations are a real invasion to a family, and they need to be identified and they need to be treated and not blown off. Doctors need to recognize them. Patients need to recognize them. We do need better treatments. One of the most important issues is our caregivers need to be honored here. So I place here a picture of Julie Carter, who is a nurse at the University at the Oregon Health Science University, and she has been a major, major person in the research of caregiver burden. And we know that caregiver burden and stress are high when hallucinations develop. Psychotic behaviors often are targeted as the person who gets the accusations is at the loving caregiver, and this is devastating. We need to protect the sleep, and we need to protect respite for caregivers, and often I recommend hiring overnight supervision or day-off staff in order to honor our caregivers. And Julie has done major work here showing how important this is, because if the caregiver gets sick, the patient suffers. We must protect both patient and caregiver, and hallucinations are one of the key problems leading to nursing home decisions. I'm at my end here. I want to go through my learning objectives and then open up time for questions. Here we go. I wanted to understand the behaviors and the experiences that fall into this category of what I'm calling Parkinson's disease psychosis. The hallmarks that I lead you with: this is a chronic and a progressive condition characterized by hallucinations or false images. I want to recognize that there are some things where there are hallucinations and agitation that are not this Parkinson's disease psychosis. Sudden illness, sudden exacerbation out of nowhere, that's usually a different condition. You want to rush to your doctor, have a urinary tract infection ruled out, an X-ray for a possible pneumonia, check your medications, make sure you're getting the right prescriptions, because that's not the typical pattern. We've talked about strategies that respect the patient and the caregiver, reducing medications if possible, keeping lights on, keeping the focus on dismissing these hallucinations, recognizing them but not allowing them to interfere with your lifestyle, and then treatments specifically for the hallucinations. I leave you this. I thank the Parkinson Foundation for this sponsorship, but also for sponsoring our study center for years and years of devoted support of a team of doctors, not just one grant here, one grant there, but a team of doctors year in, year out to prioritize Parkinson's disease and to make sure that we are on an ongoing basis trying to cure it. And I think we're making very, very substantial successes. Let me stop here, and then I will let the Dr. Beck lead the question and answer and any additional slides. Thank you for your attention.
Dr. Getz, thank you very much. That was a fantastic discussion about hallucinations. And as you can imagine, our audience has been wrapped with attention and have questions which have been pouring in. And so if I can just take a few moments of your time, let's cover some of those. One of the questions that seems to come by, and I think you touched on it a little bit, which is that when hallucinations start developing, they seem to never go away. But the permutation on that is what happens when people have these drug-induced hallucinations. Perhaps they're on a wrong medication or something, and then they taper back these medications to eliminate hallucinations. Are they they still on that hallucination pathway, or is that something that's they've put a halt to temporarily?
Right. Well, it specifically hasn't been studied that those patients who got a medication error or got a urinary tract infection, are they at a higher risk for becoming those long-term hallucinators? It has not been studied, but I can tell you it is not my experience. I have many patients who have gotten a urinary tract infection. They fall apart. You treat the urinary tract infection. You make sure they never get a urinary tract infection again. You're vigilant. You're watching for this, and they do not become the chronic hallucinators. It's a very, very different picture because the hallucinators who are in the midst of an infection, they're confused, they're agitated, where the hallucinators in this chronic hallucination status, they're usually relatively peaceful. It's disturbing to the caregiver, but the patient at the beginning doesn't find this terribly, terribly agitating and isn't confused as much as is experiencing something new. It has a different emotional coloration in most cases.
Okay. Now, so some more questions regarding the very beginning of your talk as you presented some of this long-term data that you had collected. You mentioned that there was this 10-year study you worked on with collaborators, and at the start of the study, there were a number of people who had already had hallucinations, and then many of them went on to develop it. A question's coming in from a researcher to ask how many of those people, how long people had Parkinson's disease when that study began? Were people all different stages, cross-sectional, or was it people who were recently diagnosed and then you tracked their progress?
They were all on medications for Parkinson's disease, so they were not newly diagnosed. They were all treated with levodopa. They had varying years of Parkinson's disease because what got them in was that they had Parkinson's disease, they were on medication, at least levodopa, and they were willing to follow with me. So, but they varied in terms of their duration across the different categories. So there were patients who had long-standing Parkinson's disease and yet were still not hallucinating. So just the duration of the Parkinson's disease is not enough to determine your risk of hallucinating. Age and duration sort of go together, but they don't independently and categorically determine whether you will be a higher risk for hallucinating. Cognitive decline, yes, that does put you at a higher risk for hallucinations.
Okay, that's good to know. Now, a question, a practical question's come across from a care partner in New York. When people with Parkinson's disease, they often have to enter the ER for various reasons. They're having difficulty with the ER staff understanding Parkinson's psychosis. Is there a way with which to educate them what's going on? Is there anything special to keep in mind on a practical consideration if you're taking a loved one to the ER and they're experiencing hallucinations, either treated or untreated?
Well, my own view here is if this is a chronic case of hallucinations, the emergency room is not really the best place for them. My hope would be that you can get through the night and talk to your doctor the next morning. If you are thinking, no, this is this acute, sudden development of delirium, confusion, agitation, and I'm afraid the patient has a urinary tract infection, go to the emergency room. But then you are emphasizing not the hallucinations. You were saying, my husband has Parkinson's disease, and I'm worried that he's got a urinary tract infection or that he's got a pneumonia. He's suddenly confused. He's agitated. Please, I went to this lecture. Look at the chest X-ray. Look at the urinary tract infection, and not dwell on the hallucinations to the emergency room staff because they're not going to be able to address that. That's probably too sophisticated a question. But acute infection, they'll be real good at.
Okay, that's good to know. Also, on a practical level, when people have experienced paranoia as one of their hallucination symptoms, how do you deal with that? How do you advise a patient to deal with that? And in particular, there's a question that's coming across from an allied health professional who also recognizes the importance of physical activity as a way to help control symptoms and improve overall health. Can they include people with hallucinations in their class? Is there advice to deal with, particularly, I guess, what it sounds like the most problematic symptom are the paranoia, delusions?
Well, certainly patients who are hallucinators, they can go to all kinds of classes because, in fact, most patients will hallucinate in an understimulated environment. That's why I couldn't ever get my patients to hallucinate in the scanner because that's such a stimulating environment. Most patients will hallucinate at nighttime when it's quiet, when they're by themselves. And so if they go to a class, they won't hallucinate. Now, if they're delusional and they're paranoid, they may have trouble, the caregiver may have trouble getting them to the class because they're paranoid or they're suspicious, and that can be a problem. I think if one gets to the point of paranoia and really delusional thinking that is interfering with the ability for the caregiver to get the patient the best care that he needs, and that would include, I agree with the allied health professional, that would include exercise class, that patient needs to see the movement disorder specialist and get on some treatment. You can't just watch that level of severity. That's a 4 on the rating scale, and that intervention is necessary. But for the patient who is hallucinating, I would get them to the exercise class because the more stimulation and the more interaction that the patient has, the better the patient will be, and you may be able to dismiss those hallucinations all the easier because of the stimulation.
Excellent. So along the similar lines of paranoia and delusions, comes a question that, from differentiating these symptoms from Lewy body dementia and Parkinson's disease. Is there a crossover between the two? I understand Lewy body dementia often one of the first symptoms it presents with are hallucinations. How do you differentiate PD and LBD with regards to hallucinations?
Well, it's a long discussion, and some people don't believe they're really separate. Okay, but let me just summarize. When under the microscope, when a person has hallucinations, has cognitive decline, and has Parkinsonism, under the microscope at an autopsy, it's all going to look the same. And Lewy body dementia will not separate easily from Parkinson's disease with cognitive alterations. They look the same. Technically speaking, when we try to define Lewy body dementia as different from Parkinson's disease, we say, well, if the cognitive problems start at the beginning of the illness and are coincident with the development of tremor, slowness, stiffness, gait problems, so the two are occurring simultaneously or the cognitive problem precedes, then we call this Lewy body dementia. And if the Parkinsonism precedes and then the patient develops the hallucinations later and the cognition problems later, we call that Parkinson's disease with dementia and psychosis. But the two under the microscope actually look the same. The one thing that is characterized and is kind of publicized is that delusions without hallucinations can occur in Lewy body dementia and are not common with Parkinson's disease dementia and Parkinson's disease psychosis. I think that may be true, but since the two kind of overlap with one another, I'm not so sure that we really, really know scientifically the answer to that. But from my perspective, whether I'm calling the patient Lewy body dementia or Parkinson's disease with psychosis and cognitive decline, I would need to treat the patient because the patient is suffering with the same problem regardless. And the caregiver deserves the same attention regardless. It's the same problem.
Right. So I want to just point out to our viewers and listeners that we have an online survey that's on the screen. And just to let you know that our feedback is really important for our webinars and allows us to improve them. And so please fill that out as you will. I want to thank again our sponsors, AbbVie and Lundbeck, for making this series possible. And people who have questions that we're not able to answer right now, we have excellent resources which were just shown online. And I also encourage people to call our helpline at 1-800-4PD-INFO. Just a final question or two, if I may, Dr. Getz. So when people undergo treatment for their hallucinations, there's a number of medications you discussed. Do they completely resolve hallucinations? What could people expect from them, especially as we talk about one of the new medications, which is, I guess, the first and only one targeted specifically for PD psychosis? Are they completely resolved? Is it partially resolved? What's your clinical experience?
Well, as with all patients, one can't predict 100%. One can hope that we're going to certainly improve the hallucinations and make them manageable so that the family and the patient recognize them as hallucinations and can dismiss them. That if we say, well, they have to go away 100%, I want them eliminated or this is a failure, a lot of patients will have to say it's a failure. But that's not the way I look at this. The way I look at this is I must improve them. I must improve them and get them better. And in many cases, chronically treating with these medicines gets them better and then eliminates them. So to the point where we ask the question, is it safe to stop the treatment or is that going to unleash them again? And there have been studies in those patients where they were resolved completely and you take the patient off the medicine and some of those patients stay without hallucinations at least for months. So I think there's every reason to hope that we can resolve them, but the underlying problem, I believe, is still there. And we can see this on the scans. As we improve and we treat the patients and the hallucinations get better, the scans become more and more like the non-hallucinators, but they have not gone back to being completely like a non-hallucinator. There's still that substrate that has been primed in my experience.
Very interesting. Thank you very much, Dr. Getz. I appreciate your time. And I want to let people know that an archive of today's events will be made available on Tuesday, March 6th, and you can visit that at www.parkinson.org. Dr. Getz, thank you again for your time today. It was a wonderful talk.
Thank you very much for your time. Best wishes.
Bye-bye.